discussion. So if you've attended these events before, you'll notice that I have a different background, and this is actually a real background. As I had mentioned earlier, if you didn't jump in, today I'm at the Alfred House 4 Villa, which is a brand new remodeled community in the Alfred House family of care. And we're just always trying new and different things here. So we figured today, let's do this discussion as a remote broadcast. So let me go through some housekeeping. Oh, and Bonnie Elliott, don't worry, we're going to get a tour of Alfred House at the conclusion of this discussion today. But and if anybody needs to jump off, like all of our discussions, this is going to be recorded. But let me share my screen here real quick, go through a few housekeeping items, and then we will get this discussion going. Whoops. Okay. Bear with me here. Okay. All right. So for those of you joining, I saw a couple of little comments there. I usually sort of have a countdown timer that goes 5 minutes before the discussion. And instead of doing the countdown timer, for those that arrived early, I wanted to just let everybody know that I'm at Alfred House 4 Villa, which is a brand new remodeled assisted living community in Rockville, Maryland. We're going to get a tour at the end, and we're going to get to meet Dr. Vina Alfred and Ken Silverstein here in just a moment. But before we meet them, let me go through a few housekeeping items. First off, I want to thank Maryland Relay for their support in October. Maryland Relay is an absolutely amazing free program that we can all take advantage of for those in our lives, whether they be our client, a loved one, or ourselves. If we have difficulty communicating, Maryland Relay has a lot of great free resources like caption telephones and a variety of services. I'll make sure to drop Jenny's contact information into chat. But if you're not familiar with the Relay program, every state has them, and you can learn about the Relay program in Maryland through Jenny Pearson. But if you're from a different state, she could connect you with her cohorts around the country. Just a reminder to go to proaging.com for recordings or Career Center, or provider search, and copies of the current Positive Aging Sourcebook. Later this afternoon, this discussion will be there online, so that if you wanted to share it with somebody that couldn't be here, or if you have to drop off early and you wanted to watch the end part of the recording. Next week, we've got a bunch of great discussions. Probably one of the more popular ones is going to be on Wednesday, the legal implications of solo aging. We've had a lot of discussions on solo aging. We're also going to have a roundtable discussion on ageism. And if you're in Maryland, we're going to be spotlighting the brand new durable medical equipment reuse program that the Maryland Department on Aging launched. Today, our discussion is going to be with Dr. David Wilcox. But before I bring Dr. Wilcox on, let me see if I can get Ken and Dr. Alfred on. Ken, if you, here, I'm going to prompt you to turn your video on there, Ken. And let's get, whoops. Hey, Ken.
I'm doing everything, pushing the right buttons, but I'm not.
Yep, we got you. So
because I can't see. All right, I don't see myself. So
I can see Dr. Alfred's feet right now.
Okay.
There we go. Okay, great. So
she just wanted to show her new shoes off.
Excellent. Ken, before we get into our discussion with Dr. Wilcox, can you and Dr. Alfred tell us a little bit about the Alfred House organization? And then after the discussion, we'll take a tour of your newly remodeled community.
Okay. Okay. So Dr. Alfred.
Hello, everybody. This is Vina Alfred. And Alfred House is turning 30 years old this year. We started in 1992, and we are delighted to have you all listening to us. It is such a pleasure. And I had a concept in mind, and that was to provide something out of ordinary and a concierge service. And I believe we have been able to accomplish that through this smaller facility we called Alfred House 4 Villa. Beside this property, we have other 9 facilities. Alfred House Symphony serves the residents with cognitive mental health issues. We have a medical director who comes, CNAs, GNAs, 1 to 4 caregiver, 1 caregiver for every 4 residents. That is our niche. We believe
Great.
in care and a very good quality care for all our residents. For this particular facility, we envision elderly coming in with problems, without problems, who don't want to care about cooking and housekeeping and laundry and going for groceries. We'll do all of that. We'll have a chef to cook what they want to eat and a driver to take them wherever they need to go, their transportation. And of course, a med tech and a caregiver and a housekeeper. This is our plan for this particular facility.
I love it.
There are other facilities which suit all kinds of budget. I know that times are difficult and people have limited budgets. Not everybody has a long-term care insurance, so we accommodate all different types of budgets, and we'll be glad to talk to anybody who's interested. And now I will introduce Ken Silverstein, who is our marketing director and our VP for business development. He will tell you where I left off.
Excellent. Well, thank you, Ken and Dr. Alfred. And we will link back up with you and learn more about Alfred House and this brand new remodeled community at the conclusion of our discussion with Dr. David Wilcox. Does that sound okay?
Yeah.
That's fine.
Great. Okay, we will see you shortly. So let me stop your video and mute your, and then let me welcome Dr. David Wilcox to the screen here. Dr. Wilcox, there, we got you. All right. And as you can see here on the screen there, Dr. Wilcox is the author of How to Avoid Being a Victim of the American Healthcare System. This is certainly an interesting topic to all of us. And before we dive into that, let's get to know you a little bit better. Tell us a little bit about your background and what led you to writing this book. And then we'll dive into some of the very interesting topics that you cover in this book.
Sure. Thanks, Steve, for having me today. I really appreciate it. So the first thing you probably should know about me is why I became a nurse. I'm a doctorate prepared nurse. And I had a handicap, well, I still have a handicapped daughter who lives in a group home, and I took her in and out of the healthcare system quite a bit. I was working at a manufacturing plant. When they laid me off, I was able to get benefits, and I decided to become a nurse. So I started as an LPN, and I got my 2-year degree, and then I got promoted to a house supervisor position, so I had to get my 4-year degree. Then I was in school mode, and my buddy said, let's just get our master's. So I did that. And then I went back and got my doctorate. The reason why I did that is because I have seen a lot of things in my almost 30 years in healthcare that really people need to know to be safe. It deals with, insurance companies, staying safe in a hospital. I mean, as a nurse, we go into your innermost spaces. The doctor will diagnose you, and he will say, nurse, work your magic. And that's where we pick it up. So it was really important to me as a doctor prepared nurse to let people know what's going on in the American healthcare system. The American healthcare system, we spend 17.8% of our GDP, and we're at the absolute bottom of quality outcomes. Out of 11 industrialized nations, we're the 11th. Other nations spend 8.9% of their GDP, and they have better results than we do. So we have a lot of room for improvement, and that's what motivated me to write this book.
I love it. Now, I've got your, the book is available on Amazon, but I've got the table of contents open here. And actually here, let me share my screen, because this could sort of serve as an outline for our discussion, but you've broken the book into 3 parts. The first part is staying safe in the hospital. The second part is paying for care. And oh no, let's see, part 1, staying safe in the hospital. Part 2, paying for your care. Part 3 is a better healthcare system. Let's see, why don't we sort of use this as kind of an outline for our discussion? Let's start first with staying safe in the hospital. What are some of your thoughts on this area?
Okay, so medical errors are the 3rd leading cause of death, behind cardiovascular disease and cancer, which is number 1 and number 2. In 2020, it became the 4th only because of COVID. So staying safe in a hospital is very important. So one thing I would want the listeners today to understand is that you basically have to inform your caregivers about your medications. If you're going to get hurt in a hospital, it's usually going to center around a medication. So for instance, Tylenol has 3 different names. If you get the brand name, or if you get the generic form of it, or if you get the IV form of it, it's got 3 different names. It's hard to keep up with that if you're a lay person. So what you should do is write down all the medications you take and supplements, put it on a card, put it in your wallet. And if you have to go to the hospital in a non-emergent situation, then print off several copies. Give one to the intake nurse, give one to the doctor who takes care of you, give one to the anesthesiologist and a surgeon. If you're going for surgery, they just keep handing them out, because, in electronic medical records, medication reconciliation is very difficult. It's very cumbersome, and people make a lot of mistakes there. The other thing that you want to do is you want to be able to ask them, why am I taking this pill? What is this pill? And the safest way you can go into the hospital, if it's a non-emergent situation, is bag up your pills and ask them to give you your own pills. It'll save you money, and it will also make sure that you know the names of the drugs.
Great. Okay. So then I know you've got some thoughts on prescriptions, and this is also a good segue to talk about just medications in general.
Yeah, before we do that, let me just tell you one thing. There's a part in that first part about what to ask your surgeon. So so my neighbor has to have hernia surgery, and he got a copy of the book before he found out he had to have hernia surgery. So when he went in, he sat with the surgeon and he said to him, okay, so tell me, am I going to be the first case of the day? Because statistically, if you're the first case of the day, you're going to do better. It makes sense, right? Surgeon's bright and all that. Then he said, are you going to be on call the night before? And the surgeon was like, well, no. And he's like, okay. So he asked him all these questions. Are you going to be doing the surgery? If you're in a teaching hospital, your surgeon may not actually do the surgery on you. It may be a resident or an intern. And, I don't know about you, but I don't want somebody practicing on me. If I'm paying this guy to do my surgery, I want him to do my surgery. So he asked all these questions. And he said that the surgeon looked at him like he had 3 heads. He was trying to figure out how a layperson got this kind of information. So it was quite eye-opening.
Well, one of the professions, there's several professions that we spotlight here on our discussions that are invaluable for folks that find themselves suddenly in a hospital. And one is the aging life care managers, is that oftentimes folks have used them through their decision making. So if they suddenly find themselves in a hospital, it's sort of like they call their aging life care manager. But another profession that we've been spotlighting a lot are patient advocates.
Yes.
Unfortunately, most people don't develop a relationship with a patient advocate before they go to the hospital. So if they have a crisis situation, they don't have a connection. But you're sort of alluding to the fact that most of us enter a hospital or a healthcare system, and we just listen to everybody who's got a white coat on and do exactly what they say.
Right, exactly. So you bring up a really good point about patient advocates. So in my book, I say several times, if you don't have a nurse in your network, you need to get a nurse in your network. You need to find a family member who's friends with a nurse, take them to lunch, connect with them on social media. You need to have an advocate, because if you're in the hospital by yourself, I mean, you're in the wild, and especially if you don't know the environment. So the worst thing we can do as Americans is not understand healthcare before we enter into a hospital. It'll put you in harm's way. And that's exactly why I wrote that book.
You know, what's funny? I think about my own neighborhood. We have two nurses that live down the street. And, you know, I mean, granted, we talk a lot about senior care, but the way that it works in our neighborhood is when the kids get injured, the first call is to our own neighborly advocate, this couple that are both nurses. And we call them up and sometimes do a little FaceTime or whatever. And they'll either say, oh, we can slap a Band-Aid on that, or go directly to the emergency room and say X, Y, and Z. Otherwise, you're just sort of going into an environment where you don't really know the rules and the limitations. So this is really, really good points.
Yep.
Okay. I brought up, so we're talking about staying safe inside the hospital. The other thing that I would say to the audience is just to remind you, you can ask questions at any point in time by just typing them in Q&A, raising your virtual hand, and we'll address those. But David, any other thing that you want to talk about staying safe inside a hospital, or should we move to part 2, which is paying for your care?
Sure. So if you're going to have surgery, make sure you have an advocate there. I actually did a podcast with somebody who told me that he was taking care of his wife in a hospital, and the nurse came in and drew up insulin. And he said, "What are you doing?" And the nurse said, "I'm going to give her insulin." And he said, "She's not diabetic." So things like that happen all the time. So again, just, you know, the point that you need to ask what your medications are for. If your nurse is in a hurry, just say, "You can come back to me when you have some time," you know, but don't just take it because somebody's telling you just take it. That's how mistakes happen all the time.
Oh, David, Wes Morrison just threw out a question there. Is a distinction between being admitted versus being observed?
There's different reimbursement models between being admitted and being observed, but it's pretty much the same experience. You're going to have, you know, you're going to be, they're going to watch you for 24 to 48 hours if you're being observed, but it's the same care. So there's not really much of a difference in the care if that's what you're asking.
Yeah, and I think that what we hear an awful lot of is the pressure on the hospital in terms of hospital readmissions. It's sort of,
Oh, yeah.
There's this whole game that's going on behind the scenes, and we're sort of pawns in that game. And I think that's where isn't that where they'll use that distinction of being observed, so that it's, they don't check that box that the person is admitted, because then they could get readmitted and the hospital gets pinged.
Yeah, that hospital doesn't get paid for the readmission if you're admitted and you come back within 30 days for certain conditions, such as congestive heart failure. That's one that comes to mind.
I've also got a loved one recently who entered the hospital, and it seemed like almost right from the entry point that there was this pressure to get them out of the hospital, even though they felt very safe and secure because their loved one was being observed. Any sort of thoughts on that? Is that when is the right time to be discharged, and if somebody is being feels like they have pressure put on them?
Okay, so I'll use a personal story. My wife, who had a baby, and her hemoglobin was like 5.5, and they were trying to rush her out and discharge her, and she couldn't even stand up. She needed blood. And so she said, "You can't discharge me. I need blood. I need to talk to the doctor." So if you think that your medical team isn't listening to you, then what you can do is, if you're in a hospital, you can ask to speak to the unit director, who's a nurse who's in charge. You can ask to speak to your doctor and tell them what's going on. Or you could ask at night, you can ask to speak to the house supervisor and say, you know, I'm not ready to go home. This isn't going to work for me. But you have to have a voice in your own healthcare. Like you alluded to earlier, you just can't do what the white coats are telling you to do.
Great. Man, questions and comments are coming in fast and furious. I hope you're okay with this.
Yeah, that's fine.
Okay, so Junko says, how do you hire your own nurse to go to the hospital for surgery? Like, is that a practice that is done, like where you might have somebody with you during the surgery?
Yes, there are a lot of nurse advocates out there that are for hire.
Okay.
If you Googled it, you would have no problem finding somebody.
And I will try to drop in. We've had several discussions with patient advocates, many of which are nurses. And I think that would be, especially since what you're just sharing with us, that would probably be money well spent for somebody, especially if they're a loved one or an elder and they're going through some challenging surgery.
Yes, definitely.
On the topic, when we were talking about readmission, Cedar says it's a big difference in Medicare reimbursement. And Mary Barney Butler says, yes, and prior to COVID, could prevent Medicare failure to pay for rehab. The difference between observation and being admitted.
Yes.
And folks in the audience, I know many of you in the audience are knowledgeable and experts in this area. So feel free to throw in comments there that could be helpful to all of us. And Mary Barney Butler says, it's so good to hear a healthcare professional honestly addressing the chaos in our healthcare system. Mary, it's ironic. That was the conversation I was having with David before we opened this call up. I said, you know, it's so refreshing that he wrote this book. He's an author. He's a doctorate
prepared nurse. And he's not tethered to a pharmaceutical or a specific healthcare system. He's just talking about his observations that he's seen in the healthcare system as a professional and a consumer. Let's see, Bob says, and we'll get back, I want to get through these questions and then we'll get back to the some of the topics in your book. Bob Colson says, they inform consent you, but we can't inform consent them. I received an out-of-network bill for a radiologist who did work on me without knowing this while I was in the hospital. How do we ensure all who treat us are in the network? That is a great question, Steve. So recently, I was reading an article about one of our big healthcare insurance companies that was actually taking anesthesiologists out of network. And they were doing that to use their own anesthesiologists and drive down costs. So I know of somebody locally who had a surgery and they said they did it, you know, they contacted the insurance company, they were in network, then they got a $10,000 bill for the anesthesiologist because the anesthesiologist was out of network. And so when you're talking to your doctor and your insurance company, which is something you should do before you go into the hospital for a procedure, you want to make sure, you want to ask the question, is everybody in network? Because these things happen all the time. I mean, we'll get into some of the discussion around, insurance companies and what they're doing, but insurance companies are beholden to their shareholders. They're to return 15 to 25% profit a quarter, and they're just middlemen. They just sit there, but they have a lot of authority because they're paying for your care, and they have all kinds of rules that they don't want to break. So, for instance, we'll hit prescriptions, but in 2021, in January 2021, an executive order from President Trump went into play saying that hospitals had to take 30 of their procedures and put their pricing up on the web so that you could see it in a customer friendly format. So I went to my local hospital to see what a total knee would cost me without insurance. And there were so many medical codes. I would need a coder, and I am a doctor prepared nurse. I would need a coder to understand what it was going to cost me. They don't want to give you that information because then you shop for healthcare. So if you get a total knee, if you're relatively healthy, you get a total knee done in a hospital, that may cost you, my area, $12,000. If I go to an ambulatory surgical center, it will cost me about $8,000. So they won't give you that information, but there is an app and a website called Healthcare Blue Book that you can subscribe to that will give you a ballpark figure of what it costs locally for your procedures. The insurance companies and the hospitals don't want you to know that information. They get fined $300 a day, which is about $110,000 a year. But with the profits they're making, they're definitely covering it up. They're not going to do it voluntarily. There's some legislation out there to make it about $5,500 a day if they're over 30 beds. But, I don't have a lot of faith in, politicians moving that agenda forward.
Great. Okay. Let's see. I dropped the Healthcare Blue Book into chat for everybody. Bob Colson asks, what is the moon rule? And I looked it up, and it says, the moon is a standardized notice to inform beneficiaries, including Medicare health plan enrollees, that they are an outpatient receiving observation services and not an inpatient of the hospital or the healthcare system. So, this could make a great hour discussion. In fact, that's one of the things I like about these discussions is we start going down a rabbit hole. And I think doing a full hour on observation versus admission would really be beneficial to our audience. So Bob or David, did you want to comment on anything on the moon rule?
Well, the moon rule was put in place because hospitals weren't telling you were an observation patient. So that's why it was put in place. The other thing you should know about hospitals, while we're on the subject, is when you get that survey, when you've been in a hospital, and they're asking you what kind of level of service, be very honest. They get reimbursed according to that survey. So if you had a negative experience, they'll never know it if you don't talk about it. In the old days, people just didn't talk about it, right? We just had to do what the medical community said we had to do. If you have a negative experience, lay it out there. If you have a star performer on your medical team, lay that out there too, so that person is recognized and that hospital system knows the reason why they're getting 5 stars from you is because that person excelled. The other thing you can do proactively is go to the CMS website, look at your hospital's star ratings, look at your physician star ratings. If you're going to have an anesthesiologist, look at their star ratings. And I would strongly recommend you get the name, especially with what's going on right now with the healthcare insurance entities. And, they don't care if you pay more, right? Because if you pay more, they get more. And, they give it to their stockholders. So
let me just do these 2 questions and then we'll get back to some of the topics on your book. But Cedar, I dropped Cedar's comment in chat, which says under Medicare, if the patient is sent to rehab or a skilled nursing center, if they were observed, they will be responsible for paying for the skilled nursing or rehab. Also, if the patient doesn't have Part D, they will have to pay for all of their meds. And this week it's open season now for Medicare. We had a really good discussion on Monday on Medicare and what that pays for. Wendy asks, she says, I have a severe multiple chemical sensitivity and reactions to many substances, whether alcohol, fumes, incipants, or drugs. What is the best way to flag those to be sure they will be seen and taken seriously if in an emergency I can't speak for myself? Also, other unusual health conditions that make me very worried about having to be in a hospital in an emergency. Any words of wisdom, David, for those of
Yes.
us who have these?
Yeah, so recently, you can download your medical record onto an Apple app. So you can put it right into your Apple Health, and then you can share, you get total control over what parts of that you want to share. So you are walking around with all that information on your iPhone, and you can share it with your providers as you meet them and upload it to their system. So yeah, we're finally in control of our own records, right? In the old days, I can remember people would come in and they'd want to review their records, and they had to sit with a nurse or a doctor to review their records because, you know, medical language is all in Latin. I mean, healthcare is complex, Steve, and that's not an accident. It is complex by the entities who are vying for your healthcare dollars. They keep it complex because they don't want you to know what's going on behind the curtain. And that's another reason why I wrote this book. I want people to know what's going on behind the curtain. We were talking, is it okay to move to prescriptions?
Absolutely. And I'll get to I see there's a bunch of other questions in chat. I'll get to those. And Allison, we saved the chat and we put it on the same page as the recording. So that'll be done. But yeah, let's dive into some other topics. This is fascinating, David.
Okay. So have you heard of a pharmacy benefit manager?
No. So tell us what that is.
Okay, so this guy sits in the middle of the supply chain between the pharmaceutical companies and the insurance companies. Problem is that they're mostly owned by pharmaceutical companies at this point. They've been quietly buying them up. And what they do is they make decisions. So they have coupons and rebates from the pharmaceutical companies. And when your doctor writes you a prescription, say he writes you low pressure for your blood pressure, and he writes you, it's okay to fill it with a generic form. They will fill it with a brand form if they've got a coupon that will benefit them, keep the additional money, and you will pay more money for the prescription. So here's a good case in point. I know an oncologist who was taking care of somebody with a complex medical condition with cancer, stage 4, and he wrote for a certain chemo drug. The insurance company called him back and said, we're not going to treat with that chemo drug. You're going to have to try this less expensive one. And he said, what do you mean? I know my patient's history and background. I want this chemo drug. And they said, you've got to try this other one first. And he said, I want to talk to the person who made that decision. And these pharmacy benefit managers, you can't get them on the phone. They sit isolated, they're protected, but they're making medical decisions with very little to none medical knowledge. So, you know, that's another piece of the puzzle that people don't talk about, but they're driving up drug prices like crazy.
And you know that leads to chapter 6 of your book is why prescriptions cost so much. Can you give us a little glimpse of why?
So we pay for all the research and development for the pharmaceutical industries. So our cost is a lot more than if you go across the border to Canada for medications. So you could pay $300 for a vial of insulin here, and in Italy it's free. So I mean, it's a huge injustice that we do to the American people. I can't tell you how many people I've seen that are rationing insulin because they don't know if they can pay their rent or eat. I mean, and the pharmaceutical companies are making money hand over fist. So here's a good example of a personal story. I had an English setter. She was 16 years old. Her name was Pippi Lou, and she had a heart condition. So the vet wrote for Viagra. Why did he write for Viagra? Because it was a pulmonary antihypertensive drug that had an unintended side effect, which caused it to skyrocket in price. So my wife would get a 1-month supply at a local pharmacy, and they wanted over $700 for it because, you know, it's a popular drug. So then, and this is a good piece of knowledge for you guys to know, she downloaded an app called GoodRx. GoodRx works with those pharmacy benefit managers and coupons and things like that. And she was able to find that drug for $63 for a month's supply at a pharmacy across town. The point being, if you can sell that drug for $63 and still make a profit, what are you doing selling it for 700 or greater across town? And if you go from one pharmacy to another, the price is going to change. It's craziness. And if you really need a drug to stay alive, like my wife uses EpiPen, she has to have them. We hope we never have to use them, but they're for severe allergic reactions. The EpiPen has gone up 574% from 2006 to 2016. And what used to cost you $90 for 2 pens now costs you $670. The pharmaceutical companies say it's because of demand, because they introduced some legislation, and we will talk a little bit about politics here, because they introduced legislation that schools had to stay stocked up on EpiPens, and that drove the price through the roof. But if you need a drug to stay alive, you're going to pay, and they know it, and they know they've got you. There's nothing else you can do.
Well, I put the GoodRx website in chat there, and that's a great resource for us. Okay, let's see. Let me. Well, you know what? You opened the door there, so tell us a little bit about the politics that you gave us a little preview on.
Okay, so it's amazing to me that every politician that goes into office says they're going to tackle high drug prices, right? They say they're going to go do something about it. 43 million in the 2020 election across the aisle, both sides, was distributed to our politicians. They've spent over $6 billion over a 20-year period lobbying these guys. And so our politicians are incentivized not to do anything. So I don't know if you remember back right in the middle of the pandemic that President Trump put out an executive order that we would be the most favored nation. We would pay less for our high prescription drug prices. And he said, in that executive order, he said, we'll give you 60 days. And then I want the heads of the big pharmaceutical companies to meet with me in Washington, and we'll figure it out together. So he called that meeting. Do you know how many of them showed up, Steve? 0. Not a one of them, because it's an executive order, it doesn't have any teeth. Now, solving high prescription drug prices is a huge bipartisan issue. Americans would benefit from it if our elected officials would just reach across the aisle and do it. It's something they could agree on, right? Everybody knows what's going on. It's an underregulated industry, and especially in America, you're going to pay quite a bit. But it's crickets, nothing happens. Another thing that people don't know is there's 2 types of payment structures in America. So there's fee for service, which means when I show up at my doctor's office or if I show up at the hospital, they get paid. They're incentivized to write tests on me, right? So, I might get an extra test here or there or something like that. But there's also this little known payment structure called value-based care. And in value-based care, you're in a network of physicians. They are incentivized to keep you healthy. So they get a certain amount from the insurance company. And if they keep you healthy, they get to keep the profit. If you don't stay healthy, and you access the system, then you're going to create expense for them. So when they want you out of the hospital and healthy. And so a good example of that happened to my brother-in-law. He had under a bundled payment, meaning that they paid a certain amount of money for his hip surgery. He was under a bundled payment. So he had to stay in network, and they did the surgery, and they gave him an opioid pain medication. Now, this guy doesn't drink. He's never done any drugs as far as to my knowledge. And so when he went home, he started to have chest pain. So away he went to the hospital. And when you get a cardiac workup, that costs a lot of money. And so the next day, a nurse came out to the house, called my sister and came out to the house. My sister was saying to me, oh, it's great. The nurses are coming out every day to check on him, and it's all free. And I said, well, sister, it's not really free. I said, they're looking for their best interest because they got paid a certain amount of money for his surgery. And when he went to the ER, they had to eat it. And they had to pay it themselves. But value-based care is really the answer to driving down the costs. And take the pandemic, for instance. So hospitals and we as taxpayers bailed them out because they weren't making enough money and we had to keep them viable. Well, that's a fee-for-service problem. Under value-based care in 2020, they actually saved $4.1 billion. In fact, they were trying to get a bill into the infrastructure package because they thought they could save an additional $313 million by pushing value-based care out. There's some physicians that are hesitant to do value-based care, but the ones that do it and they do it well, that's the model. That's where you want to be taken care of, because you have better outcomes. They show that you get your flu shot 17% more of the time. 34% more are going to get their annual eye exam, because they are incentivized to keep you healthy. And that's what healthcare is all about. That's putting the care back into healthcare. Yeah,
and I dropped a definition from the Cleveland Clinic into chat on value-based care. This is great. This is the first time that I've heard of that. Let me go back to a couple of the questions that are here. And first, let's see, I'm going into chat. I saw one from Bonnie that was good. And she said, Bonnie Elliott says, not everyone can afford an aging life care manager or a patient advocate. Is there anyone at the hospital, like a care manager or social worker, that can objectively assist a patient?
Yes, and that's a great point. You can always ask for a care manager or a social worker. Usually most of the emergency departments have one in there, and basically because of that observation rule and admission rule, so that they'll look at what the doctor writes and see if the observation patient meets the criteria, and sometimes they're allowed to change it depending on, you know, how the policy is written at the hospital.
Let's see, Mary Barney Butler says, do we have a bona fide value-based care here in Northern Virginia? If anybody in the audience knows, by all means, throw that into chat. I'll do some research on it. But David, I know you're based out of North Carolina, but is there a way to identify where value-based care providers are nationwide?
That's a great question. So this is what you should do, because this sends a very strong message to your doctor. You ask your doctor if he's part of an accountable care organization. Accountable care organization uses value-based care for you. So ask him that, because it sends a message. Because if he's not, and he's getting asked that question by 20 patients, he needs to get in a network. That sends a very strong signal. If he's not, then you can ask him, where is there an accountable care organization that could treat me around here? So now he knows he's losing your business, right? So the funny thing about value-based care is I read a survey that only 25% of Americans really know what it is. The other 75% don't know. And so if you don't know, you're not going to do it. And of course, insurance companies aren't going to be out there advertising this. So check with your doctor, ask about accountable care organizations, go on the web and search for your area to see who has it. I think Sientra is a big entity out in Northern Virginia. So I would be surprised if you didn't have a value-based care accountable care
I just did a quick search, and CMS, which I dropped it in there, CMS, Centers for Medicare and Medicaid Services, talks about, they've got several links on their website where you can find accountable care organizations. So that's really good. And I definitely am part of that 25%, and I'm in the healthcare business here. So thanks for that. Okay. All right. Bob Colson says, I gave each of my local hospitals my advanced directives so I can be sure they will access them if and when they're needed. So that's very forward thinking there, Bob. Let's see. Diana asked, can you give your opinion on Medicare Advantage versus Medicare Supplement Plan and Medigap policies? I'm not sure if that's an area of expertise for you, but just your thoughts on that.
I dabble in it. Medicare Advantage, if you're in a value-based care organization, is definitely a plus. If you're not, if they have you in a fee for service, I'd stay away from it. But you have the right to ask that and say, I want to be in a value.
Whoops. Uh-oh. Oh boy. David, if you can hear me, you just lagged on us. And it might, I hope it's on your end and not on mine. Can somebody type in chat if you can hear me? And Okay, you can hear me, we just can't hear David. So David, if you want to log out and log back in again, I think that's the best solution. And okay. These are tech. Okay, so we'll get David in a moment, but you know what? The good thing is that if I've got Ken and Dr. Alfred, if you could turn on your camera and mic while we're waiting for David to get back on, we could start our tour of Alfred House, which we're visiting here. And oh, I got to prompt you there. Okay. So if you just tuned in, okay. So Ken, I think, oh, there you are, David. Okay. Oh, here you go. Unmute. Hit that unmute button.
Me to do the tour?
Yeah, sorry about that. My connection drops and that never happens to me.
Okay, and then Ken, sorry about that false alarm. We'll get back to you at the conclusion here. Okay.
Okay.
All right. Okay.
And maybe it was a pharmaceutical company interrupted my connection. I don't know.
Yeah, exactly. They don't like that we're talking about them. Okay. All right. So let's see. That was a little distraction, but we were talking about the Medicare Advantage and what have you.
Yep.
Okay. Let's see. Bob says, don't the social workers get paid by the hospital too? Like, is there, I mean, the previous, obviously, if you can afford to have this objective third party advocating for you, that's great. But one would think that a social worker in a hospital, while they're being paid for a hospital, they also have their code of ethics for their profession. And I know it's not a perfect world, but I'm assuming that that you should be able to get them to advocate for you a little bit more.
Yes, I've never, and in my hospital career, I've never seen anybody who didn't perform ethically in that role. But the best thing that you can do is get a nurse in your network. Doesn't cost you anything. I can't tell you how many times I get hit on my phone. Somebody says, hey, I'm going to the hospital. This is what's going on. I'm like, you got your medications with you? Do you have this? Do you have that? You know, I mean, so if you have a nurse in your network, that's the best, because nurses want to help people. I mean, we didn't get into this for the money. We got into it because we wanted to help people. Hence why I wrote this book, so I could help people. So when I was,
we've all been at barbecues where one of our friends or family is a nurse, and they discover after the fact that a loved one was in the hospital, and you hear this time and time again. They'll be talking about the challenges, and it's like, well, why didn't you call me? Oh, I thought you were too busy. So one great idea that I think you're clearly advocating for is that if you've got a friend, a family, a loved one, an acquaintance who's a nurse, check in with them and just say, hey, you know, I was on this discussion today, and I realized that if I ever need to go in the hospital, is it okay that I give you a jingle? And I think 9 out of 10 are going to be like, absolutely. And if you don't, I'm going to be upset.
I think 10 out of 10.
So somebody asks, do you provide any healthcare consultation services and or healthcare advocacy services? Thank you for your book and your hard work. We need this very much. Yeah, is that something that you offer, David, or you know?
Not at this point. It's something that I've toyed with a little bit, but you know, I'm pretty busy with this book and my day job and all the other stuff I've got going on. So I thought it was more important. So, you know, when I was in the hospital working in an ICU, I could help 2 patients over a 12-hour shift. When I became a hospital administrator, I could help several nurses take care of patients, which broadened my perspective. When I went into healthcare IT, I could change the way a community, doctors at a community practice. And then when I finished the doctorate degree, I thought, what's the best way to help people? And I thought, you know what, write something that they can understand, give them a handbook on how to move through the system. What do they do when the insurance company denies them? What do they do when they run into that high price prescription? And most importantly, you know, how do we have a better system? How do we move from fee-based services to value-based care? So that's why I did. I'm trying to be an advocate in that area. Now, there may come a time where I do something different, but that's where I'm at.
Yeah, but I threw David's email into the chat there, and honestly, that's what makes you a great guest on this discussion is that you're like, if you said, oh yeah, I charge by the hour or what have you, you're very objective. And that leads to Bob's question, which is, how is the medical community responding to your book? Have you received any sort of pros or cons or any comments from the community?
So I was actually in front of about 900 nurses yesterday, virtually, talking to them about the book and about why it was important. And what I'm hearing from the medical community is, thank you for writing this. You know, we saw this going on all the time. For instance, in my book, I talk about one doctor when I was the night code nurse, hospital administrator. 80% of the patients I saw were coding because they were touched by this guy. He had bad hands and bad judgment. You know, we didn't have star ratings back then for you to go to CMS and check them out. And that's why I encourage you to do it. And I went to administration. They were like, keep monitoring the data. And unfortunately, there's a terrible story in there of a young mother who had just given birth who died because he missed something. You know, that kind of stuff happens. And, you know, you couldn't do anything different in that situation. But I can do something different now, that's for sure. I can get American people to understand, go to that CMS star rating site, check out your doctor, get yourself to value-based care where they're incentivized to take care of you. That's my passion.
Great. Bob follows up, he said to our thing about the nurse as a friend strategy, is there any way that a nurse would get in trouble for sort of providing that type of guidance? Good question, Bob.
So let me share a personal experience, Bob, because what happened to me one time, I was in the grocery store and I heard this woman talking to a friend of hers and saying, I'm going to go to this hospital where I work and get this procedure done by this doctor. And I knew the doctor didn't have good outcomes. And so I was wrestling with it because I'm like, what if I say something and she reports me? But it wasn't really about me, right? Now that I look at it in hindsight. Walking up the frozen food section, this woman's coming dead on right in front of me. And I said, hey, I couldn't help but hear what you said about getting your procedure done. And the doctor, oh yeah, he's got a wonderful bedside manner, which he did. And I said, so I can't tell you who I am, but I work at the hospital. And I said, and you don't want your procedure done by him. You want to find another doctor. Could I recommend so-and-so? And she said, she looked at me kind of shocked, but she said, thank you. So yeah, there are repercussions if you're tied to the organization that you have to be careful. I couldn't have gone in there on the day of surgery, Bob, and said, you know, hey, don't get your surgery done by this guy, you know, unless you want to spend many months recovering. But in a grocery store, I could do it. So yeah, there's some tricks to it, unfortunately.
Okay, yeah. So bear in mind, and you know, if you are asking a friend for feedback, just recognize they're an educated friend, you know, so, okay. We've got a couple of questions, a question and a comment that I'm going to drop into chat here, and it relates to MOLST and POLST. And MOLST, if you're not familiar with, it's medical order life-sustaining treatment, and physician order for life-sustaining treatment. And person asks, can you explain and talk about these two signed directives? And if your wishes are that you do not want to be taken to the hospital, can you protect from being taken to the hospital if you're concerned? And I dropped those into chat for everybody as well.
Yeah.
So any thoughts on MOLST and POLST?
Oh, yes. In fact, in my book, I remember what chapter it is. There is a chapter called Making Your Wishes Known, chapter 5.
Yep.
You should definitely read that at a minimum, because that dealt with my stepfather and my mother. So you have to have those things posted on your refrigerator somewhere, you know, and so if somebody calls EMT, they are supposed to look for that document on your refrigerator. So, you know, you don't want to, If you don't want to be treated for end-of-life care, you got to make sure your wishes are known. In the book, I talk about my stepfather got in an accident and he carried his DNR in his wallet. Well, they revived him. He broke every limb. He had a terrible time with it. It was at the beginning of COVID. And I said, did you find his wallet? Was the first question I asked them. And they said, no, we haven't found his wallet. Well, they located it and found the DNR, but it was too late. He had been resuscitated. Now, my mother in that same chapter, she was having a heart attack, and I knew her cardiac system, she wasn't a good candidate for open heart or anything like that. So she actually, and she was pretty scattered, she grabbed her forms and, that the power of attorney that they would call me, her living will, and she went to the hospital with it when they picked her up in the ambulance, and they called me and said, your mother's here and she's having a heart attack. And I knew that was the end, but I even messed that up as a medical professional. They're like, can we take her to the cath lab? Can we put a tube in? I went into sun mode. I was like, oh my God. I said to my wife, what do I do? And she said, tell him to do it. And so I did. And about 3 minutes later, I got a call back that the picture had changed and that was not an option. Thank God for that, because I would have beat myself up forever if that happened. But yeah, all that to say, whoever's going to be your advocate at the end of life, make sure they totally understand what you want. You have that discussion, because we're all going out at some point, right?
Yeah, and this is advanced medical directives is something that I feel like we talk at least once a month about here. Okay, I'm looking at the clock and we're getting close to the top of the hour here. Susan Schiffman says, where on the CMS website does it give ratings of doctors, or is there a place where that you trust to get ratings of doctors?
Yeah, you can look on the star rating system, Susan. So you would want to narrow your search down to star ratings. You could do hospitals and then you can do doctors. Without actually logging on and showing you, it's kind of hard to walk you through it.
Okay, so star rating.
Yeah, it's the star ratings.
Okay,
they're rated 1 to 5.
And then I'll look that up and see if I can help out. But what I'm thinking, Dr. Wilcox, to sort of close things out and wrap things up, and I'd love to have you back on again. You're fascinating. But chapter 15 of your book is where do we go from here? Without blowing the plot of the book, can you give us some insights on where do we go next?
So we saw during this pandemic that many of the healthcare agencies that were tied to the government, like the WHO, the CDC, the FDA, were coming out with all kinds of wild recommendations, right? Wear a bandana. And they did that because they didn't want you scarfing up masks and things like that. What we don't have in this country is an independent council of clinicians that can actually disseminate information and are not tied to any kind of payment structure from the government. We saw a lot of, dumbing down what clinicians were saying and things like that during the pandemic, which happened to fall during an election year. But we need that. That's, if you can get trusted clinicians, because a lot of people don't trust those agencies anymore. In fact, 2 people from the FDA actually quit over the booster shot because they didn't see enough data that said, that was a good strategy. So big pharma, the flu shot that you take every year is a variant of the 1918 flu. When this whole pandemic started, they knew they were in a 100-year strategy. That's why they dropped everything and went to make vaccines on our taxpayer dollars, except Pfizer, who didn't take any money. So, they know what they're doing, and booster shots, big money for them. It's 5 to 10% more efficient. You got to weigh it out, but there's not a lot of big science behind that says that that's the way to go. Great.
And then Wes Morrison asks, what do you think of the website Health Grades that grades doctors and hospitals?
That's another alternative. Yes, definitely. Yep, I forgot about that one.
Yeah, but with all of these websites, I mean, a lot of times, whether it be a doctor, a lawyer, or what have you, make sure that you sort of look at the about part of those websites and just make sure that you're not sort of falling into kind of a pay-to-play type directory, which I know we've got quite a few of those in every category. Not to say that some of those can't be helpful, but you just need to sort of realize that. And I think working with websites like CMS, you know, that are government or nonprofit based, JCO, you know, things like that, you've got a better chance of an objective. But I also like to sort of remind people that just because somebody has a rating by any given organization, bring that rating up to them as a provider. When you're looking at them, it's like, hey, I just searched this up on my phone and it said this. Get their feedback and what have you.
Yeah.
So
and Steve, I also have a website. It's drdavidwilcox.com that you can access to. I've got information up on that.
okay, great. I'll make sure to put that on the recording page. And David, I'm so glad that our paths have crossed, and I know that our audience, based on the comments that we're getting, are very excited too. And let's stay in touch. And I'd love to bring you back on again, because I think we could go for quite some time. But so thank you. I'll share this with everyone. I'll share your contact, and we'll be talking to you soon. And then David, feel free to go back to doing your thing, and we're going to get to touch base here with Ken Silverstein now with Alfred House and get a tour of this community that I'm in. Thanks,
Thank you,
David.
Steve. I appreciate you having me on. Take care, everybody.
You bet. Okay. All right, Ken, let's give this a shot. If you want to unmute and turn on your video, we can work on getting a tour.
Okay. Thank
Okay.
you. I did want to just share some. I don't know if David signed off or not, but I started using GoodRx a couple of years ago, and went into the pharmacist, and she went on a tirade about how this is going to put pharmacists out of business because of the reduction in the cost. I'm like scared to go in there now and give a prescription because she just went off on me.
Go to another pharmacy. Yeah.
Yeah.
Okay. So first off, before I kind of hand off to you, if somebody can type into chat, Ken, keep on talking. I want to make sure that people can hear you. Okay.
Okay. So welcome everybody on behalf of Alfred House. Dr. Alfred just had to leave. She had another meeting. But she thanks everybody, and thanks to Steve for allowing us to do this. The Alfred House 4 Villa is literally just been completed. This past summer was completely gutted, the inside, and modernized and contemporized, and it's just simply gorgeous. I'm right now in the master suite, which I'm now referring to as my room. So this can actually hold 2 people if need be. The house overall will hold 6 residents, and Dr. Alfred explained to you the concept of the concierge. So everything in here is literally brand new. This bathroom is, everything is ready, move-in ready.
Great.
Yeah.
So what I'm going to do, Ken, is this is good. Keep on giving the tour.
Okay. I'm going to show the closet. This is So now I'm going to head back out to the main part. Again, this house holds 6 residents. There's 4 on the main floor and 2 downstairs. This is a sample of one of the rooms upstairs.
This looks great.
And then it is a shared bathroom, which is directly across the hall here. And then as we enter this bathroom, we can come into another room. Dr. Alfred worked with an interior designer that she used for Symphony House as well to do this. And they literally had books of furniture on the conference table in the office, just going through. She handpicked everything to the throw pillows.
Well, I'm here, and it really looks beautiful. You did a great job, and I'm really excited.
Yeah, it's really
you and Dr. Alfred.
Thank you. Then we have another room here, resident room here. And then I will take you downstairs where we have 2 private rooms, both with a private bathroom. We also have a sitting area down here in the office. Down here, the meds will be locked up down here as well. This is the common area. And then, as I said, both rooms downstairs have private bathroom. Private bathroom here, shower. This is the bathroom to the other room. I mean, just beautiful tile.
Yeah, it really looks great, Ken.
Yeah. And over here is just another walk-in closet. We're having a little work
Excellent.
done on that. So, yeah. And then this is, as Steve said, this is a very, very private residential area back here. So, and location-wise, for those of you who know Montgomery County, we're basically across the street from Leisure World.
And asks, how much is the monthly cost?
So the price point starts at $6,000 for level one, for one of the rooms upstairs.
Great. And then for those of you who showed up a little bit late, this is, you get to see the beautiful neighborhood. You get to see this, what I love is an accessible entryway.
Oh, yeah.
With no barriers to entry.
And there is a deck on the back as well. And we're good neighbors. We take good care of the landscaping. Matter of fact, we were raking leaves this morning. So we are good neighbors.
Well, this has been awesome, Ken.
Thank you.
And it's sort of a first of a kind thing for us here with our digital discussions. And hopefully we'll do more of these because I think it's a great way to sort of spotlight different providers that are out there and what they're doing. So thanks for being the guinea pig for us on this.
Well, thanks for having us.
And what a great discussion today with
Yeah,
Dr. Wilcox.
Really was. Yeah.
Okay, so I'm going to go inside, turn off my computer.
Okay.
I'll send the recording to everybody.
Thank you, everybody. And please call me if you have any more questions about Alfred House Villa or any of our other 9 homes in the county. Have a good weekend.